Yesterday we started off with cat scratch disease. Remember, a scratch, a bite, a lick from a cat or kitten can spread that Bartonella Hensley, right? So we ended up with the lab section. Here, this is technically a clinical diagnosis. We don't really have to do stuff for this, right? But if you do need to do something, remember the most common one is that lymphadenopathy, right? Especially in them little kids. So we could always do a biopsy of that and send it off to the lab. Okay? You can do IFA, you can do ELISA, that IgG, IgM stuff. Just remember that this the Bartonella species has over 30 different ones, so we're not quite sure which one will pop up, which is why the box is a little bit better. If you do have PCR wherever you are, again, PCR is the best way to go for almost everything that it's available. Right? Very specific, very sensitive, particularly for the DNA. All right. Treatment with immunocompetent, generally self-limiting, right? We talked about that yesterday. Biggest deal is if those lymph nodes get really big, they're going to get really tender and they're going to hurt a lot. So you may have to drain some of those. You may have to aspirate them. All right. But generally overall, self-limiting. There it tells you symptomatic for the lymph nodes, the pain, the tenderness. Just go ahead and drain. If you do need to treat, the treatment will be a macrolide. Specifically for us here, it will be azithromycin. Right? Azithromycin will be your drug of choice. Remember that oculograndular syndrome, right? If you get scared because you see that giant conjunctivitis and the bright red eyes, right? If you're just not comfortable with that, make sure you send them to the ophthalmologist. But you need to make sure that you educate your patient and let them know that it's self-limiting. Okay? They're not going to spread it to somebody else. And it may take about 6 weeks for it to go away, whether you do anything or not. Okay. The scarier part is that it does mess up their vision a little bit because of the inflammation and conjunctivitis. So remember, if you are uncomfortable with it, get it over to the ophthalmologist, right? Not the optometrist. All right, Toxo. Who's got a cat that looks like that? You guys said you have pets? No? Nobody? Okay, he looks rough, right? Looks like he's been through some stuff. So toxoplasmosis gondii, that's your obligate intracellular parasite that's causing this problem. Do you remember Toxo when we talked about HIV? Remember, this is an opportunistic infection, right? It likes to affect people that have low immune systems, right? So on this side, when we're going to talk, not only do we need to refer to the immunocompromised, but we're also going to talk about those other folks, particularly babies and pregnant women that may be more susceptible to some of this stuff. All right. This can be passed from mother to child congenitally. That's a transmission method, so you're going to spread it to your baby if you have it. It can also be spread via blood transfusion or organ transplant. And so there's quite a few different ways that we can spread this thing. Okay? But it's generally attributed to foodborne illnesses. Okay? And remember, most of us, a lot of us, carry this already in our system. It's just sitting there dormant. All right. Here's a whole bunch of the sources, right? Feces from acutely infected cats, most common. So remember, whenever we talk about most common, those are the things that you really need to kind of hone in on, right? So you have a pregnant lady at the house. She's got a cat because she's a cat lady, and she's changing all these cat litter boxes. Okay? That really predisposes her to toxoplasmosis. Right? So we want to tell pregnant women, don't mess with that stuff when you're pregnant because we don't want them to get this parasite. Right? So most common. But you can also get it from undercooked meat, Here it's got a whole bunch of different ones, reindeer, venison, tapir. Okay? You can also look at some of the more common ones like rabbit and duck. Okay? Those can also be affected by toxo. So if you're eating those kinds of meat undercooked, you may end up getting some toxo here. Here's got some horse meat consumption in France. Remember, I told you, depending upon where you work or where in the world you are, it's going to be the most common thing. So whenever you get to wherever you're going, you can ask some of the folks around you that have been working there for a little while, hey, what's the most common stuff around here? How do we treat some of these things? What do you guys use to treat MRSA? Right? Because every place is going to have their specific drug regimens for certain things. Okay? Here they've got some deer stuff, Middle Eastern dishes made with lamb, okay, raw lamb. Those can harbor some of those toxic issues as well. When you think about those, right, we have guys that go out there and talk to a lot of these areas in those Middle Eastern countries. Okay? I've been part of some of these things. The Air Force has a great global health engagement team. Those guys go out all the time. Okay? We are making our global health engagement teams to mirror theirs. But understand, these are the soldiers that we're going to be taking care of. This is where they're going to be, so let's try to keep those things in mind. And there it tells you, in underdeveloped countries, so unfiltered or untreated water appropriately may also spread. So there's quite a few different ways to get it, right? Types of household stuff. We really direct this most common to cats, right? So if you have an indoor cat, the most common part will be that cat litter. If you have an outdoor cat, then it's an outdoor problem, especially if he is coming into contact with other animals or other cats that may be infected. Because if they get into fights with those things, they may spread it to your cat, and then your cat will come home and spread it to you. Okay, so just keep those in mind. And remember those little kittens, right? Those little kittens can shed those oocytes for as long as 3 weeks even after they've gotten better. That means that your little kids, if they're playing with those little kittens, can end up getting this as well, right? That's why a lot of us already have this innately inside of our systems. Just because we're healthy, it doesn't really bother us. So here, the big thing to remember from this is that if you have family members within that same household, those family members should also get checked. Okay? Especially pregnant women and or immunocompromised folks, because here it tells you family members having acute toxo had one or more family members also with acute toxo, which means they can give it to each other. All right? And it's extremely concerning when we talk about pregnancy and we talk about immunocompromised folks. We need to make sure that we can protect those people, right? So a newly infected toxoplasma during pregnancy can pass it to the unborn, calling it congenital toxoplasmosis. Right? If we end up with a congenital toxoplasmosis, it can affect the unborn child, it can affect its nervous system, it can affect its eyes. It can cause a lot of different issues for that unborn fetus. Okay? So we want to try to prevent that. So if we can prevent it, remember, key to infectious disease prevention, right? If you learn anything that we continue to go on, that'd be the big piece. Right? Prevention is a big key to infectious disease. Okay, so here's a little path. 80 to 90% of folks, right, like you and I, healthy folks, no issues, no problems. Okay? Our immune system can handle this. The problem is for those that are immunosuppressed. Remember, when you become pregnant, you may become a little immunosuppressed because your body's doing some other things, right? What about those HIV folks? What about those neutropenic folks? What about those folks that are on chemo? Okay, all those folks. What are those folks that are on long-term steroid use? All those people. Okay, become targets for toxin because this is an opportunistic infection. And those are the guys that really get hit up bad with this thing. Okay. For folks like you and I, no issues, no problems. Okay. This thing usually likes to invade the intestinal epithelial cells. Right? You guys remember that stuff from the little diarrhea stuff that we did in the last block? Right? Okay, these parasites replicate inside those epithelial cells, inside the inside the intestinal lining there. Once they do that, they break out of there and then they start going to wherever they want to go. Okay? Liver, eyes, brain, okay? Their choice. Your body tries to fight it. As it's fighting it, they end up becoming radiozytes. Okay? When they become radiozytes, they become dormant, and they're just there. Our body's just taking care of it. That's what happens with a healthy person. Okay? Pathophysiologically, right? But when we don't have that immune system to hold them at bay or convert them to a dormant stage, is when they start running rampant. Okay? And they start causing a whole bunch of different issues around your body. So here's what we may look like. Okay? Mononucleosis-like syndrome. That'll be us. Healthy folks. Right? So you guys remember mononucleosis-like syndrome? Fever, sore throat, swollen lymph nodes, fatigue. Right? Some of that stuff may not be on here, but that is the expectation for your understanding. So if you guys want to write that down, you can. Fever, sore throat, swollen lymph nodes, fatigue. Along with some of the other things that are on there, right? That cervical lymphadenopathy is one of the biggest things that we're going to see when we talk about toxology as well. Okay. And then you have the rest of your symptoms yeah, that our immune system will generally take care of. Right? So we'll be sick for 1 to 2 weeks. It may take us another 2 to 3 weeks to get better after that, but self-limiting, and we usually take care of it for healthy folks. Right? For the immunocompromised folks, it's when it becomes a problem. Right? You guys remember when toxo actually started becoming a serious problem for an AIDS patient? You guys remember that CD4 count number? What was it? 50. Yes, look, she got it right. She got it right. 50, right? So less than, CD4 count less than 50, okay? It's usually when this stuff really starts affecting AIDS patients or the immunocompromised folks with AIDS. So once we have it identified, right, we have 2 targets. We have ART therapy because we want to get those things back up, and then we want to target the actual infection. In this case, it would be the toxo. All right. And there we've got non-AIDS patients. It attacks the central nervous system 50% of the time. So all those central nervous system signs and symptoms that we've talked about before are still the same. None of those change. Right? The only thing different between neurologic infections, whenever we have them, is it's dependent on the area of the brain that is being affected. Right? Each part of the brain controls a different part of your body, so that's really going to gauge the type of signs and symptoms that you'll end up having. Okay. So you see all these big giant masses here, right? Here's one, here's another one, there's another one. These are your ventricles. Okay, here's another one. This is the back of the head. This is the front of the head. So all those things are toxo in the brain. Okay. So here we're going to talk about some congenital toxo, most severe disease in early pregnancy. Okay. Remember, mom is healthy. If she gets toxo, she may not have some symptoms. She may be asymptomatic. Right? Which means if you, as a provider, aren't checking the pregnant patient for this, then we may miss it. We may end up catching it later on, but that might be as it starts affecting the infant. Right? So here we're kind of sort of talking about at birth. On the next slide we'll talk about the congenital aspect. Okay? So here at birth, you may see some anemia, thrombocytopenia, jaundice, microcephaly, or hydrocephalus in the infant. Okay? In the infant. If mom hasn't, we will recognize it. Okay? Usually these babies, some of them are usually asymptomatic. And the problem with them being asymptomatic is that we just don't know, we don't see anything, which means we have to let them develop a little bit before we start seeing some of the impairments that they may have, such as visual impairments, learning disabilities, or seizure disorders, which are another possibility of what these things can cause. Okay? So for congenital chorioretinitis, you guys remember that one? Back of the eyes really jacked up. Right? Average onset's 4 years. So it's for the ones that are usually born asymptomatic. Right? As we continue to develop, and we'll see as they continue to get older. Okay? South America, Colombia specifically, has some serious problems with this. We have a lot of this there. Okay? Some of the other aspects that these babies may have, we have to wait for them to continue to develop in order for us to realize that are mental retardation, seizure disorders, visual defects, spasticity. So the sooner we can catch this, hopefully we can prevent this in pregnant women with your babies. Here's that chorioretinitis. This one's really, really bad, right? So if you look at here, right, you look at cup to disc ratio here, right? There is no cup to disc because this cup is almost completely obliterated here. Right? All your vascularity that's supposed to be going around here is completely gone. That's some giant wool spots here. You got a whole bunch of almost looks like necrotic retina in the background, so this is pretty bad, right? Here's your hydrocephalus in congenital toxo. Right? If you come out like this, it is noticeable. Okay? So we don't have to wait till they get a little bit older to realize that they do have something. Okay, so what do we do? Toxo is usually made by detection of toxoplasma. Okay, specific IgG, IgM, IgA, IgE antibodies. Okay, and you can pull it from blood, bodily fluid. Here they've got amniotic tissue because if you're not sure, you can go ahead and draw some amniotic fluid from the baby's or from the pregnant woman's belly and send that off to the lab. Now remember, if we're thinking it's central, right? If we're thinking it's nervous system, central nervous system, right? We usually would go ahead and do an LP. But before we do an LP, what do we need to make sure? What is it?
Pressure's good.
ICP, correct, right? We make sure that there's no intracranial pressure, right? Because if you do have increased intracranial pressure, you do not want to do a lumbar puncture. Okay? That is a contraindication. So this thing lights the brain. Okay, so CT would be great, especially if you're thinking that maybe there's something in the brain and you do have some intracranial pressure before you choose to do a lumbar puncture. All right. Now, I need you to know this slide. All right. Here it tells you asymptomatic host, no treatments are usually necessary. Exception usually in children less than 5, so go ahead and treat children less than 5. But I need you to know the bottom. Okay? The important part in the magic number for pregnancy is greater than or less than 18 weeks. Alright? If they are greater than 18 weeks, you are going to treat them with 3 different medications. Chlormethamine, sulfadiazine, and leucovorin. If they are less than 18 weeks, you're going to treat them with 1 medication, spironolactone. All right, the combination of this triple antibiotic is to target the Toxoplasmosa gondii parasite. That's what we're trying to do with the triple therapy. Okay? The leucovorin is a folinic acid. Okay? That's to help reduce the risk of bone marrow suppression associated with the arrhythmia in pregnancy. Okay? So that we're trying to get rid of those parasites so it does not affect the baby. Okay. So the magic number greater than or less than 18 weeks. Question with those two treatments? No? All right. I think there's going to be one question on test. I think. I haven't written. All right. But usually I do at least one. Okay. So for this slide, you can disregard that bottom there. I was going to give you all the big ones, right? So for cerebral toxoplasmosis, got peripherin, sulfadiazine, and leucovorin. Same as treatment for pregnancy, right? Okay, big difference. Here, those would be like at 2,000 milligrams, 200 milligrams, and 25 milligrams. But again, I'm not going to be concerned with the milligram dosing, which when I read the bottom part is for your suppression following therapy. So if you do have cerebral toxoplasmosis in an A patient, you're going to give them a high dose of those 3 medications. 6 weeks after that, you're going to check to make sure that they're clear, and then you're going to put them on suppressive therapy, and you're going to continue to follow them for a long period of time. Okay? That's generally the way it works. That's what that little bottom medication of 500 to 1,000 milligrams orally 4 times daily. That's supposed to be your suppressive therapy. Okay? Don't worry about that. That part I am not going to ask you about. I will just ask you about the medications. Okay? So both for acute and for suppressive, you're going to use the same exact medications. All right. What didn't go onto this slide is the one for primary prophylaxis. All right. For primary prophylaxis, we're going to use trimethoprim, sulfamethasone. Okay. Trimethoprim, sulfamethasone. Right. TMP, SMX. That will be for primary suppression. Right. So if you do have positive IgG and you do start getting a low CD4 count, but you don't have the symptoms and you don't have a problem yet, which were an 8th weekend, I may start you on that to prevent you from getting it down the road. Okay? That's what that primary prophylaxis is supposed to do for you. All right? A lot of times the magic number for that one is if it drops below 100, right? We know the magic number is less than 50 for toxo in AIDS. But usually when we see CD4 count less than 100 of those guys, we'll usually go ahead and put them on primary prophylaxis if they have not shown signs of the disease. All right. If they do show signs of the disease, then we're going to go ahead and shoot triple antibiotic therapy. Right. Anybody have any questions about that? No? All right. Now we're going to go to mycobacterium. What was the other mycobacterium that we talked about? Tuberculosis, yes. TB, okay. That was another mycobacterium. Okay. Because these are also mycobacteriums, these are also going to be acid-fast bacilli, which means you can stain them with some sort of stain in the lab, or you send it off, and then you try to wash that stain off, and the stain doesn't come off. Okay. That is a telltale sign that they're acid-fast bacilli, okay, which is one of the markers for all mycobacteriums. Okay. Okay, marinum. Sounds like marine, right? Water. Marine water, not marines. Okay, so keep that in mind. So Mycobacterium marinum, aka fish tank granuloma. You can get it from salt water or fresh water. A lot of times you'll see it mostly from people who own tanks, fish tanks at home, where they go in and they try to clean out their tanks and they scratch their hand on something inside that tank. Okay, or they kind of get their finger or hand cut by the fish or whatever they have inside that water. Okay. This is slow growing. All but one of the ones that we're really going to talk about today are slow growing. Okay. Like the bacterium itself is slow growing. Okay. Found in fresh water, found in salt water in different parts of the world. It really attacks the skin and it's a soft tissue infection. What it is, right? Here it's got a couple of different things: aquarium, saltwater, marine animals. Okay. Sometimes you will see this in scuba divers and snorkelers who may not wear hand protection or not quite sure where they are when they're in the water, and they kind of scratch themselves on rocks, on coral, may hit other things that are in the water and scratch themselves. Okay. That opens them up for a possibility of getting exposed to marine. Right. So they're following skin trauma. As that little area grows, it usually forms a little granulome. That's the initial presentation. Okay. The other big thing, do you guys remember sporotrichotic lymphadenitis? Do you remember we talked about that? No? That's sporotrichotic lymphadenitis. Is that if it happens someplace, wherever it happens, on your arm, on your leg, right, it gets into your lymphatic system and starts tracking your lymphatic system up or down, away from the initial point of incidence. Okay? So let's say you scratch the back of your hand, right? Your lymphatics run in your entire body, right? You guys remember that part from anatomy? Right? So once you get infected on your hand, it'll burrow down to get to your lymphatic system, and it'll track your lymphatic system up your arm or down your hand. Okay? Either or is choice. Okay? And what happens is, right, think of it as water. So it's up here, it's got a little granuloma poking up, starts going down, makes it to the lymphatics, it swims its way up a little bit, and then it has to come back up for air, so it pops up, causes another granuloma, and then it pops back down and keeps following that lymphatic system as far as it can go until it gets treated or taken care of. That's what that sporotrichotic lymphadenitis is. Okay, so kind of specific for this one, right? So something to know. This thing usually looks like a little line. Okay, maybe a little squiggly, right? Depending upon how your lymphatics lay out in your body. Okay? And they could be little batches of small reddish lumps. Okay, if they're not, as time goes on, they'll become granulated. Okay, follows an abrasion and exposure to water, 90% upper extremity. Most common is usually the forearms. Right? Those are most common. Papules and nodules at the wound site. So wherever you got scratched or cut is usually where you'll get that granuloma. Right? 25 to 50% of them become sporadic, sporotrichotic type. So you have up to 50% of the folks that get it. You may see that little line going up or down away from the original point of injury. This thing doesn't usually become systematic. It said it's usually skin and soft tissue. And then there is a slight potential for it to go deeper, right, causing you some tenosynovitis. Remember, hand is one of the most common, right? So there's not much here. Okay? If it gets there, it's pretty close to your ligaments and tendons, right? Pretty close to your joints as well. So just keep that in mind because of the most common place that it usually is. All right, that's what a little granuloma looks like. So this one already looks like it's starting to become granulomatous, right? So your lymph nodes go all the way, your lymphatic system goes all the way down and goes all the way up. Maybe this one's already starting to grow and down. Okay? So it may have started here, gets into your lymphatic system, and it pops up here, And if it continues to grow, it may pop up further down. Okay? Or if this was the initial incident, it may follow it up and pop up here, and then as time goes on, you'll continue to move up or down your lymphatic system. Okay, here's some nodules elevated. Usually they're greater than 1 centimeter. Okay. Excuse me. So this one can be a lymphatic. A much better picture for that, right? So we'll say that this one looks like it may have been the initial incident, right? So you can see that it's going up his arm, and you can see that it's also going down his hand. All right, and it may just be following this lymphatic system. Usually we don't spread this person to person, so no serious concern that we're going to spread it to each other. All right. You got to communicate to the lab, let them know that this is what you're specifically looking for. Okay. Because if it is, there's when you're trying to culture the best temperatures for it to grow at. The other big thing about this is that it's photochromic. Okay? So if they grow this in the dark, as it continues and starts to bud, the buds will look white. So it'll look like this one right here on the left. So if you grow it in the dark, it'll look like this side. Okay? If you grow it in the light, it's going to look this side. It's going to look yellow. Okay? Two completely different looks. Okay? If it's grown in the dark versus grown in the light. That is part of what photochromogenetic is. Okay? That's for this particular species. Alright? Now remember, this is a mycobacterium, right? So if you were to do a PPD test on this guy, you'd probably pop positive because it doesn't denote the difference. It just tells you that there's some sort of mycobacterium. So you have to be careful with the mycobacterium if you're checking for PPD. Treatment, erythromycin and ethambutol or ethambutol and rifampin. Okay. Pick one. Generally, most common one will be the clarithromycin and the ethambutol. Okay. All treatments are minimum of a month to 6 months. Really depends on how bad it is and how deep it's gone. Right? If it's really gotten into those lymphatic system, we probably have to do a longer treatment. All right. They don't usually have to do surgical excision, but depending on how deep this thing goes, is whether or not you do or you do not have to involve those guys. All right. Mycobacterium ulcerans caused by Ballooning ulcer. Okay. This is a chronic necrotizing skin and soft tissue infection. Okay. It's the third most common mycobacterial disease worldwide, after tuberculosis and leprosy. Okay. Typically found in Africa and Australia, right? You also find it in Southeast Asia. Okay. West and Central Africa are the most common areas within Africa that have this. Okay. It is a slow-growing bacteria. Okay. Mode of transmission can occur through environmental exposures to water, ponds, rivers, swamps, soil that's endemic to the region, mostly tropical and subtropical areas. Okay. Now here's a whole bunch of animals that could possibly spread this thing to you. The big one that I really noticed on this is dog. Right? Because dogs are really common for us as household pets. But depending upon where you are in the world, they may have pigs, they may have horses. Okay. Another big one that's on here is koalas. Right? This is the second time we've seen koalas on here. Or no, first time we've seen koalas on here. So, hey, something to keep in mind, right? Okay, this one usually presents as a painless nodule or papule that becomes a painless ulceration. Right? I want you to keep that in mind. As we continue forward with these pictures, I want you to keep that in mind. Nodular papula becomes a painless ulceration. All right. It's going to have some undermining edges on that ulceration. It's going to start leading to a bunch of tissue necrosis, okay, or tissue destruction. I want you to keep that picture in your head, right? Because this is a massive skin and soft tissue loss. All right. But remember, this is slow growing. It can make it all the way down to your bone, expose your tendon and ligaments, how bad the ulceration can get. But I want you to keep that in mind as we move forward. Okay? We're in Western Africa, Central Africa, okay, Australia. Okay, so remember most common Western and Central Africa. See that? Do you think that's painless? Does that look painless? Okay. When I first look at that, I would say, oh, hell no, that's not painless. Right? So it's important to know what you're really looking at, because this guy's telling you that it doesn't hurt. Right? This looks necrosis to me. Right? This whole area already looks dead. This whole area here looks dead. Right? So do you think necrotic tissue causes pain? Do you think loss of blood starts causing pain? Do you think necrotic tissue will allow healthy tissue to regrow?
No.
No, it will not, right? So we're probably definitely going to have to use surgery on this guy, right? Generally, this guy does not have any systemic symptoms, right? We said this was a skin and soft tissue issue, right? Generally, no systemic issues. Painless. It's crazy, right? That is one of the ways that you really know. Like, oh my goodness, okay, let's think it's M. ulcerans for now, right? Until you can kind of figure out what's going on. This specific bacteria produces a unique toxin that's called mycoactone. Mycoactone. That's not going to be on your test, just FYI. Mycoactone causes necrosis. It causes apoptosis. You gotta remember that cell death, right? And it also causes immune suppression and suppression of the immune system overall, and it damages on your nerves, right? So right off the bat, ain't nothing to help you get better, and it's killing your nerves, so nothing's hurting, right? That's why this guy is painless, and that's because of the specific toxin that this particular ulcerans, M. ulcerans, is causing the person. Right? Now, if there is some sort of secondary infection that may occur to this, which is highly likely because there's a lot of exposure there, okay? Right? This whole area over here still looks a little juicy, right? If it does get down to your bone, okay? Even more possibility of exposure to possibly getting a secondary infection. If you do get a secondary infection, that may cause some pain. Okay? But when you initially look at it, no pain. Okay? High clinical index of suspicion, especially from endemic countries. As we said, give an ID. It depends on where you are and what you got wherever you were. So this would be a high clinical index of suspicion if you are in Central or Western Africa. Do we have people in Western and Central Africa? Yes, we do. Yes, we do. Okay? Again, keep that in mind because our population that we take care of do end up in some of these places. All right, so these may be some possibilities. Okay? We can do an acid-fast bacillus because it is a mycobacterium. And then, if you do have PCR. Best thing to do, PCR. Especially if you're trying to catch it early. Because PCR will catch things early. The other thing you can do is you can swab it, and then you can send it off to the lab, and then you can figure out what it is. Alright. Here, you've got medications. Okay. Combination of rifampin and clarithromycin. Okay. So rifampin will be part of both. So you'll either pick clarithromycin or moxifloxacin, one or the other. Generally, we use rifampin and clarithromycin. That's usually the standard versus rifampin and moxifloxacin. All right. Now you saw how big that thing was. As it continues to eat away at your tissue, the tissue dies. We want to get rid of the dead tissue. The dead tissue will inhibit the healthy tissue from growing over, which means surgery has to be involved. Okay. Once we get rid of all the bad stuff, right? Once we get rid of all the emulcerates, we have multiple choices. We can do let it grow by secondary intention, which means we leave nothing but healthy tissue and let it grow from the inside out. Or we can get rid of all the bad tissue and we can degraft it and cover that thing up. But that's not for us to decide. That would be up for the surgeon to decide. Okay? And lamprey, aka leprosy, aka Hansen's disease. There's quite a few different names for this thing. If you guys remember the history of leprosy, we used to have leprosy camps. Not just here, but around the world, because they thought this was extremely contagious and people would die because they would get it. Now we know better. Okay, now we know better. You need to have a lot of close contact. You have to rub stuff on each other. Okay? So not as easy to spread as we thought. Okay? So no more leper colonies, no more any of that stuff. Okay? Part of what we need to explain to our patients. Here, typically found in tropical and subtropical regions. There's a whole bunch of places, Asia, Africa, Central and South America, Pacific regions. So there's a lot of places that you can find it, but the next statement pretty much tells you, look, you have it here in the United States. Florida, Texas, Georgia, Arkansas, Louisiana, Alabama, right? But look, have been known to harbor infected armadillos. Okay? So you want to highlight something, highlight that, because I may put that in that scenario. Okay. This is the second time we've seen armadillos. Right. Armadillos is not the only way to get it. But on the slide. Okay. Usually hangs out in the little pads, especially when the kids play with them. You start poking at them. You want to push on their feet. And that's generally when most of this infection usually hangs out. So the little kid can get it. Okay. Not highly contagious. Most likely a respiratory droplet issue, which is how we get it. Okay. We need to make sure that we have prolonged exposure to spread it to each other. So, okay, that's where we think of parents, that's where we think of spouses, significant others, okay, when we talk about close contacts with some of this. All right. Skin-to-skin contact, especially with open wounds, someone who's infected can also spread it. Direct contact with nasal secretions or an infected animal can spread it. Okay. Now, we need to make sure that we treat this thing. Okay? Because if we don't, this thing can leave very crippling signs and symptoms for your individual patient. Okay? This thing can cripple hands, feet. It can cause paralysis, and it can cause blindness. This thing can cause a lot of bad stuff. Okay? So we need to make sure that if we do get it, we go ahead and treat it, right? As soon as possible. The earlier that we find this and treat this, the better off the patients usually end up. All right, so here you have lamprey on skin infection. Leaves a lot of these papules and nodules that you just saw there, all over the body. Okay, this one you can see really well. Okay, these are just slides of stained lamprey. Excuse me. So, ulcers, macular lesions, erythematous nodules are typically painless for this thing. Okay, typically painless. Right? You can look at that right arm. See that stuff doesn't really hurt, right? But as the nerves continue to get affected, they may become painful. Involvement as it continues to develop will start causing you to have weakness and muscle loss. All right? This is affecting your nerves, affecting your nerve impulses as well. This thing has an affinity for your peripheral nerves. They like to invade the Schwann cells. You guys remember those from neuro? Yeah, I don't remember that stuff from neuro. Nope, I don't remember neuro at all. Come to this place. Right? But it replicates inside those Schwann cells. And inside of those Schwann cells, as it's replicating, it causes nerve damage and it causes inflammation. It causes demyelination and it causes fibrosis. And as it's causing all that, you as a patient continue to lose sensation. When we talk about sensation, we talk about temperature sensation, we talk about touch, right? And we talk about pain, right? So right off the back now we know that this thing is painless for a reason. Okay. Now one of the other things that's kind of different with this one is that once you start treating this, pain may return. Not necessarily at the initial site, but around that site. Alright? Because you'll start getting neurologic signs back once you start treating this thing. But the chronic initial lesion will still be there, and that one still won't hurt. Okay? So skin lesions with diminished sensation accompanied by peripheral neuropathy is highly suggestive of leprosy. And that's the stuff that we just talked about, right? Neurologic disturbances and motor imbalances occur as the nerves are infiltrated. That's where the demyelination comes from. Okay? Bilateral ulnar neuropathy is highly suggestive. Right? So if you have stuff on both sides, right, of your body, it's more of a disease process than it's, if they say, hey, it's probably just from one side. Okay? Usually when you have a disease process, overall, choose your entire body, not just one side of your body, right? Unless we talk about stroke or something like that, right? Untreated leads to skin disfigurements, extremity leading to digit loss, right? That neurological effect. Okay? What do? We can do skin biopsies, we can do nasal scrapings, send it off for acid-fast bacilli checking. You can do a PCR, okay? That's probably one of the best things you can do. You can do a skin biopsy, send that off. So you've got a couple of different choices here. Right? But when you treat, you're treating with 3 different medications: rifampin, dapsone, and clofazimine. You're treating with 3 different medications. The earlier you get these medications on, the better your outcomes are going to be. So you do have a really good outcome when you use these meds on leprosy. All right, let's go ahead and take a break. This one is the only one that's different than the other mycobacteria. Okay? The other mycobacteria, remember I told you they were slow growing. Okay? This is the only one that's rapid growing, grows really fast. It's found all throughout the environment. Okay? Water, fresh water, salt water. They've found it in artificial water sources, hot tubs, fountains, water treatment plants. This thing can also become an opportunistic infection for those that are decreasing immune response. Right? So this thing is rapidly growing mycobacteria. Found in water, soil, and maybe some dust. Okay? It causes skin, tissue, and eye infections. Okay? It can be an opportunistic infection, especially when you're immunocompromised. Now, the other difference aside of being rapid versus slow is that you may find this one in hospital settings, clinical settings, more so in aesthetics. So for the folks that have cosmetic surgery done, folks that get tattoos, this is a possibility. Okay? This is a possibility for those guys. You don't usually spread it person to person. The other big difference with this one is that this one is also resistant to a lot of standard antibiotics. Okay? Now, has been associated with soil frogs and turtles. I can highlight that. That's a lot different than the other ones. Just told you that it's in the water soil and could be by some aquatic animals. Really a skin and soft tissue infection. So everything we just covered, right? Tattoo related cases have been done. Alright. So it's not just the tattoo ones, it's also the cosmetic surgical ones have been found to have N. colonia. So most common areas, there you go. Alright. Here it's telling you there's a manufacturer that had some contaminated ink that spread this stuff to other folks. So it's not just here in the US that this could happen. Here you've got practices in foreign countries. The water that they use to dilute that ink over there, you don't know what kind of water that is, right? So maybe getting contaminated water, you don't know. So that makes other folks overseas a little bit more prone. Right? Not necessarily here in the US. Here, usually we have a single needle use, you throw it away, nobody else gets it. We have regular water in our system, and we know it can be treated appropriately compared to underdeveloped countries where they don't. Right? Other places they have seen this are some spas. Okay? So remember cosmetic type stuff and clothing. Now, here you can see right, the rash is just all over, pink, red, purple, bluish, all over the place. Start spreading across your skin. Usually red, purple nodules, they're usually painful. You may get some abscesses, you may get some boils. Okay? They're filled with pus. Okay? You may get some ulcers, you may get some open sores. Okay? You may get some papules, so that's your whole first line there of what this thing can actually look like as it starts spreading across your skin. Invasive and disseminated. Okay, so in immunocompromised people, right? Because we said this is an opportunistic infection, it can go all over the place. Okay, and this is rapid growing, unlike the other one. So this one can spread really, really fast. All right, unlike the other ones. So for this one, we're going to use tobramycin or clarithromycin. One or the other. Now, the other serious problem that we have within cloning is that we have noticed a lot of resistance. Okay? So if you do think it is this, it's not on the slide, in your essay, you should do a culture sensitivity. Okay, you should do a culture sensitivity for antibiotic resistance with this one. Now, we have had cases where the single antibiotic has not worked, and we have had to go to 2 antibiotics for this one. Right? So, for now, all you guys need to know is pick one of the 2. But if you do end up having this, right, just make sure you do culture sensitivity, figure out what antibiotic really works for it best. Right? Drugs to bugs, right? You guys remember that? Drugs to bugs? Okay? So you would use specifically drugs to bugs for this one because it is becoming more and more resistant. Okay, lepto. Okay, pathogenic spirochetes, leptospira. Okay. Distribution worldwide, usually in the tropics. So look at all those cool places you can go to where you can actually pick up some lepto. All right. So when you're going to go on vacation, just keep that in mind. All right. Now remember, the other things you guys do are travel docs. So if your patient comes to you and says, "Hey, I'm going to go to one of these cool places right here, Puerto Rico or Hawaii," hey, possibility to get that. All right. Keep that in mind so that you can kind of sort of educate them on the possibility of what they can get. All right. This is just a bacterial infection transmitted typically to humans through direct or indirect contact with urine or bodily fluids from infected animals. Okay. Most common is usually rodents. Infected urine from rodents. Okay. This can also get into the water, right? So if you go in the water, you have broken skin, stuff can contaminate you from the water as well. And there, if you look at the very last statement, second to last statement there, lepto is now considered an emergent disease in travelers. Right? So we got folks like me who have come to you, hey, because I like to travel, so I'm going to come see you. Okay, I'm going to go here. What do I need? Okay. So you let me know, hey, be careful wading around in some water if you have any breaks in your skin. And a lot of times folks who are laying contaminated soil, if they're camping out in those areas, can also get infected. Right. So direct contact with bodily fluids of acutely infected animals, exposure to soil or fresh water contaminated with urine. Most animals are usually chronic carriers. They'll carry it in their urine, spread it around. Right? We don't know where they go. But if you're out there hiking and camping, okay, you're in their environment. Okay. Right? Some of the more common animals would be those rats, dogs, cattle, horses, sheep, goats. Okay? All these animals we usually keep for farm animals. So there's a possibility, depending upon what you have, is that you may get this. Now when they get infected animals, if they don't get treated, they can spread it in their urine for years asymptomatically. They're just chronic carriers. Okay. Now if you see the bottom here, high risk activities. Okay. I advise you to remember some of those because that'll probably be on the test. Okay. Freshwater soil and animals such as hiking in the jungle, kayaking, and swimming in water. Okay. Remember those most common. Right? Those most common are going to help you. Right? This thing usually enters through the breaks in the skin or the mucosa. Okay? So your eyes, your mouth, your nose will contaminate your water, soil, or animal. It gets into your system. Once it's in, it gets into your bloodstream, and it just goes wherever it wants, right? Most likely liver, kidneys, lungs, central nervous system. That's what it does. Incubation period is usually about 7 to 12 days. And what this thing does is it binds to your endothelial cells, disrupting that tight junction. You guys remember when we talked about hemorrhagic fevers? And we said, hey, these things got in and they went to your endothelial cells, right? This thing kind of does the same thing. It goes to your endothelial cells and it disrupts the junction of the endothelial cells. So those are the linings of your vessels, right? And when it does that, it creates what? Vasculitis, right? Inflammation of all your vessels, one, right? It creates capillary leakage. If it continues on, it can create hemorrhage, right? So it's going to cause a whole bunch of different things, all right? So overall, it causes your endothelial lining to start getting destroyed and damaged. Right? Very similar to some of the hemorrhagic stuff that we talked about before, but not as bad. Now, the problem with this one is that it can also affect your organs. Okay? And you may end up having some organ failure later on. Okay. Now, when those junctions start getting, or your endothelial cells start getting invaded, right? What comes out to help? What comes out to help? Somebody tell me. So if you get infected by leftover, your body's going to come out and try to stop this and kill it. Macrophages, right? Macrophages and neutrophils specifically for this one. When those guys start interacting with the bacteria, they start fighting, right? And then you have all these cytokines that come out, interleukin 1, interleukin 6, tumor necrosis alpha, all these big cytokines. That sometimes makes things worse, right? When you have all these things, sometimes it creates a hyperactivity of overinflammation in your body that also worsens that capillary junction, the tightness of those capillary junctions, worsening some of the leakage, worsening some of the hemorrhage. So there's quite a few things that kind of sort of work against us when we're trying to take care of ourselves inside our own bodies. Okay? So we're going to really talk about two types, the enteric, right? Enteric being jaundice type stuff, right? Jaundice type stuff being liver. Okay. And enteric, most of us may get, right? Here it tells you 90% of these cases are enteric. That's great because it's self-limiting. They show up as mild flu-like symptoms, right? Cough, sore body, aches, headache, right? But it's self-limiting. Wonderful. No big deal, right? No big deal. Okay, so no jaundice, but you'll have some fever, headache, chills, nausea, vomiting, right? Okay. We can handle that. Usually lasts about 1 to 2 weeks. Goes away on its own. No big deal. But when we talk about the enteric leptospirosis or wheal disease, okay, that's when things start getting a little bit more. That stuff does cause you jaundice, okay, because it's affecting the liver. Okay, it does cause buildup of the bilirubin. Right? Remember when we talk about buildup of the bilirubin? One of the main reasons why you start getting jaundiced, right? Turning yellow. Okay, and this thing can affect your liver, it can affect your kidneys, it can affect your lungs, it can affect your heart, it can affect your brain, it can affect a whole bunch of different things. Okay? This thing can lead to organ failure or organ death if not addressed. Okay? So the second one is bad, but it's only 10%. So you got a 90-10 shot, right? Getting it right. So which one are you going to figure out? Which one you're going to get? You're going to get the 90% or you're going to get the 10%? 90. 90? So at least you got a good choice, right? I would go to 90 myself, right? Right? So we always want to know, which one am I going to get? Which one is the patient more predisposed to get? Right? Generally, we don't know. Okay? Multifactorial, remember, as we've spoken for our entire time together, it's really dependent, right? Depends on your health, depends on your nutritional status, depends on your immune system, depends on your age, depends on a whole bunch of stuff, right? Are you healthy? Not healthy. Are you immunocompromised? Yeah. Those usually have bad outcomes. But a lot of it is really dependent on the lecto itself. Right? There's over 250 recognized serovars of lecto. Over 250. Which one? I don't know. Which one causes what? I don't know. They don't know either. Okay? So we go with the 90-10. All right. So there's lots of possibilities of why you would get one versus the other. All right. Okay. So if you have the enteric lepto, there's a whole bunch of possibilities that you can have. Right. A lot of this is really dependent on what organ is actually being infected. Okay. Now remember, this thing does like the urinary system. So kidneys may be one of those places that this thing may affect. Okay. So multi-organ involvement. Here's your temperature. You can go up to 104, so you're talking some high temperatures, right? Burn, some headache, nausea, vomiting, diarrhea. There's a whole bunch of stuff. I would highlight the bottom one, right? Muscle pain, calf and lumbar areas is classic for lepto. Okay, it is classic for lepto. There are some small instances where you may end up with some hemorrhagic issues, right? You may have some hemorrhagic manifestations, right? Because remember, if you talk about the pathology of this disease process, it decreases the tightness of your junctions and you have capillary leakage and possible hemorrhaging, which means you may have some hemorrhaging. Okay? You may have some hemorrhaging into your eyes. Right? It's not on here. But just remember, as we continue to talk through the pathology aspect, we can talk about how you get some of these symptoms, right? And some of the symptoms that may not be on there. This thing can lead to azotemia, this thing can lead to anemia, right? Diminished consciousness, right? Quite a few different things. So here's some hemorrhagic manifestation or some conjunctival redness caused by lepto. So confirmation of the disease, isolation of the lepto. Okay, very simple. Take a look at it, put it on the microscope. Okay. You can do tissue, you can do bodily fluids, typically urine. As we said, this guy likes the urinary system. So have it in a cup, and take a look at it, and see if you can ID the little bug. Okay. Here it's got period acute convalescent serum. You guys remember that? Either EIA or ELISA. Okay. Just remember you do one initially, and then the other one you can do 2 weeks later, okay, for verification. See if stuff is going up or down. Right? Urine is really the best one within the first week or so. But if you do have PCR would be the best one. Okay. So if you do have severe lepto, you're going to treat with IV Pen-G. Let me just say this. We have not spoken about Pen-V or Pen-VK at all. Have we? Okay. But not for this. Okay. Not in this block at all. Okay. We haven't spoken about Pen-V or Pen-VK. So if you think it's this, don't pick Pen-VK or Pen-V. Pen-G. Pen-G. IV. This person needs to be hospitalized. Okay? If it is severe. Okay? Severe ones, we talk about old people, we talk about immunocompromised folks. Okay? We talk about folks that are enteric. Okay? Those are the severe ones. Okay? We talk about enteric and they're getting a little freaky, then okay? Outpatient therapy, PO doxy. Okay? Outpatient, PO doxy. Questions? No? All right. Questions? No? All right. We shall move on. You guys should probably be teaching me about this stuff because you guys are doing neuro, right? You guys doing neuro? You guys done? You guys done?
One more block.
That way? One more block? Okay. So you guys could probably teach me about this stuff. And I know absolutely nothing about it. So you guys can tell me everything you guys know. Alright? Since you guys are actually in neuro. Alright? But encephalitis or meningitis, real simple. Okay? Nothing really big about this. You remember we saw encephalitis and meningitis in almost everything that we've done thus far, right? All those viral and bacterial issues can eventually lead to encephalitis or meningitis because they can either cross the blood-brain barrier, get into your central nervous system, or retroactively get into your brain, right? Your olfactory system, right? So simple stuff. Inflammation of the brain, other meninges, right? No biggie. Most common are viral. Most common are viral. Out of the viral, most common, HSV. Herpes virus. Most common, number one. Okay? Most common bacterial is usually strep pneumoniae. Okay? Well, there are two most commons that can cause this thing. Right? Now, there is a slight prodrome. Oh, talk about encephalitis. Talk about encephalitis. Prodrome is going to be severe headache, myalgias, and malaise. That'll be your prodrome for encephalitis. And then meningitis has a triad. Okay? The triad for meningitis is fever, nuchal rigidity, and mental status changes. Fever, nuchal rigidity, and mental status changes. These are all usually encompassed with fever anyway. All right. Yeah. So real quick, overall encephalitis, inflammation of the brain, right? Most commonly, it's usually viral. Most common is usually viral for encephalitis. In bacterial infection, you get severitis, and severitis is just the inflammation of the brain tissue that causes. It's caused by some sort of a bacterial infection. Okay? That's been spread by the blood. That's literally what that means. Spread by the blood, spread by bacteria, spread by surgical or trauma issues, spread by the olfactory system, spread by anything. Here you've got primary and secondary type infections. Primary virus directly invades your brain and your spinal cord. Okay, so that is what it's going to go do. It's going to go directly invade your spinal cord or your brain, causing meningitis or encephalitis. That's your primary. Okay, that's real simple, right? That's what its target is. But when you do secondary is a lot of the stuff that we talked about since we've been together. You've got a bunch of all these disease processes, and then if you let some of the disease process go out of control, then it tends to wander over to your central nervous system. Okay. Here's a whole bunch of different things that can cause encephalitis. There's a lot of things that can cause encephalitis. Here's a whole bunch of choices you have. Okay, so I'll be smart and say, hey, what can cause encephalitis? There you go. Here's a whole bunch of things that you can just spit out. Right? So if you remember, we talked about a whole bunch of these already, and as part of those complications, encephalitis or meningitis have been a lot of what we talked about. Okay. That one specifically at the bottom, N-Fowleri. Okay, that one's also known as the brain-eating amoeba. All right, that's actually found in warm water. Okay. Lakes, rivers, usually geothermal areas. Then we just finished talking about toxo. We're not going to get into any specific pathophage, right? Because this thing can enter any way, right? Because we can talk about viral issues, we can talk about bacterial issues, we can talk about arthropod issues. Any of those things can cause encephalitis. All right? Just remember, from human to human, the reactivation one is a big one. Okay? The reactivation one is a big one, especially for immunocompromised folks. Because the reactivation just tells us that we've already had it in our system. Our immune system has been keeping it at bay and taking care of it all this time, but now that our immune system is dropped, it's reactivated. Some of them that hang out in our nervous system, like herpes simplex, reactivates and just starts causing more problems. Okay? And can eventually make its way to the brain. That would be more so for those immunocompromised folks at the bottom. Okay. There's quite a few different ways there. You have once you cross the blood-brain barrier, stuff usually happens. So when we talk about acute encephalitis, inflammation and edema are usually what cause a lot of the problems. Okay? So your immune cells come up to fight, right? The bad stuff that's going on would be those neutrophils or macrophages. There's a special cell in the brain called microglia. Okay? It is a precursor of a macrophage. Whenever things are attacked, those microglia get called or convert over to macrophages already in those areas, and it fights. Okay? You have CD4 T cells. You have CD4 T cells, right? CD8 T cells. CD8 T cells are very specific for viral infections. The CD4 T cells are non-specific. They will just come to help fight. Okay? Now, when you have all these things going on in your brain, what do you think is happening? Say again? Correct. Inflammation. It's a double-edged sword here. Okay? Not only is the bacteria or the virus or the fungus or the parasite causing problems and causing irritation and inflammation, but now that your body is trying to fight it, it's causing more inflammation. And when you have more inflammation, things tend to swell, right? And when they're inside your cranium, that bad boy's not going anywhere, right? So you're kind of squishing down your brain, so now you're causing other types of symptoms to occur as well. So these are the things that we have to also keep in mind as this thing continues on. Okay? Okay, some signs and symptoms, focal and diffuse presentations. All right? None of these are things that we haven't known before, right? There's your stiff neck when we talk about encephalitis, usually more common with meningitis, but it also occurs with encephalitis, personality changes. That is one of the main reasons why people bring their friends or family members to the emergency room when they have these types of issues, because their personality completely changes. So none of these symptoms are anything that we don't already know. Now remember, depending upon which part of the brain is being affected, infected, or pressure is placed upon, is the real big type of symptom that you're going to have. Right? Just keep that in mind. Because here at the bottom you've got generalized and localized seizures. That's some pretty bad stuff right there, right? But again, based on what part of the brain is actually being affected. So here's some physical symptoms, some physical signs. Right? Alert, mental status, and or personality changes. Right? One of those things that you need to write in your SOAP note is alert oriented times 3. Guys remember that from ClickCore or from Psych? Or what? Yes, person, place, or time. Correct. Right? This person is not going to be alert to person, place, or time. Okay? Again, they may have their lucid time periods, so they may be okay for a little bit, and then they'll go back down. And that'll be all things that you do during your HPI. HPI, extremely important. Here you've got focal findings, a whole bunch of different seizure type issues there. But again, depending upon which portion of the brain is being affected. Right? Here you've got your autonomic dysfunction, okay, which usually occurs when your autonomic system is infected or affected, and that generally controls, you guys remember what it controls? Well-being, maintenance, balance. Okay? You're not properly regulated, you start getting all wobbly. Okay? So, good neurophysical. Okay? From that HPI, you should be doing. Labs and diagnosis. What do we generally do? Do we do a CT or we do an MRI? CT. Well, that's CT right there, right? There's your answer. We'll also do the CT to check if they have intracranial, if they have mass effect to cause, to check for intracranial pressure as well. Because if we think this is neurologic, we'll probably do a lumbar puncture, right? But if we do have that intracranial pressure, we're probably not going to do that. But the CT will come tell us if there's something going on in there. Now, if you are in a place that can do MRI, and you do have intracranial pressure, MRI is also a much better choice because you have a more defined view from an MRI. Yeah? If you do have something going on in the brain, the MRI can actually tell you what that is. Okay? So it's a lot more sensitive, a lot more specific than the CT. Okay? If you do have the availability, but remember, CT's fast, CT's cheap. CT also has radiologic issues that you can absorb, and it is not as precise as an MRI, which is more expensive, but definitely more precise. And that's radiation. We don't usually mess with electroencephalography. I was shown how to read that one time. I don't know how to read it. It's a whole bunch of squiggly lines that if you don't do it all the time, just like EKG, if you don't do it all the time, you forget. Okay. So generally we don't mess with that, but the neurologists usually do to see if there's anything going on in the brain. Okay. So they like to look at it, make sure everything's going okay. And that CSF, pretty essential. Okay? Later on, as we go through this, I'm going to show you a little chart so it can differentiate whether it's viral, bacterial, normal, or what it may be for your CSF results. Okay? General treatment, mostly supportive, right? Everything that we talked about, whether it's said supportive or not. Remember when we started, I said, hey, everything will be supported, everything. Regardless of whether we have it on the slide or not, supportive treatment is key for all of these things. If we get to a point with someone with encephalitis that cannot breathe, cannot do certain things, that supportive care is really what's going to get them over that edge, right? And so appropriate management of that airway is key if this person needs it. And then we look at everything else, the electrolyte fluid balance, nutrition, any kind of secondary infections. But remember, something is causing it. We just need to figure out what that something is. Right? That's that little detective hat that the ID person has to put on to figure out what it is so that you can direct the treatment towards it. Right? And you saw that one slide, there's a whole bunch of things that can cause it. That was not an all-encompassing slide. There's way more stuff in there. We just need to figure out what that is. Okay. And then again, if you do end up having intracranial pressure, elevate the head, gravity will bring some of the fluids down, right, from the brain. Diurese, get some fluids off the body, decrease some of that pressure. Mannitol will decrease the pressure in the intracranial, and then if they do have any kind of seizures, give them something to control those seizures. Right? Herpes simplex. Right? We said this is the #1 viral reason for encephalitis. Okay. Still exceedingly rare, maybe subacute. 2 cases per 1 million people. Okay. Reactivation of the herpes simplex virus in your system. A large percentage of us already have this in our system, sitting dormant in our dorsal root ganglia. It's in there. When you start going down, it starts coming back out. Right? Here it's got mortality rate of 75%, if not addressed. Okay. Central nervous system spread for HSV is through the olfactory tracts, right? So right here, face plate, it's gonna go straight into your brain, right? Because you have your olfactory senses, and it's gonna go straight up into your brain. Easiest way to get it. Easiest way to get it. And that is a nerve that goes straight up into your frontal lobe where your olfactory system is. So that's that. So it completely bypasses that blood-brain barrier that a lot of folks concern themselves with. Okay, you got HSV 1 and 2, subacute forms. Alright. You can do those mini mental exams for the psychiatric issues. That's anterior ventricular syndrome. Two is loss of excuse me, of voluntary control of your face, of your facial features, of your pharyngeal, of your linguistics, of your masticoid muscles. Okay. So if you do have that, again, that goes back to the supportive treatment. Here it tells you 1 is usually the brainstem, 2 is encephalitis. May produce some myelitis. Again, that cross, not really important. Okay, not really important. If it does get into the brain, it may cause you some global aphasia, but again, that's really dependent upon where in the brain it's actually being affected, right? PCR DNA is probably the best way to do it. You don't have to necessarily do any kind of lumbar puncture. Cyclovir is the treatment. If you remember when we talked about HSV, since cyclovir has been out specifically for encephalitis, it has dropped it from 70% to 17% survivability. Right? And cyclovir came out like around 1984, like mid-80s. And now we've got better ones like valcyclovir. That one will do better. Okay, arbovirus, that really just stands for arthropod-borne viruses. As we mentioned before, any of those arboviruses can cause encephalitis, right? That inflammation of the brain. If you let them go long enough, those can be caused by mosquitoes and ticks, doesn't really matter. If you remember those from when we talked about them, one of those complications was encephalitis and meningitis. Nothing big. Most common times of the year, usually June and October. Birds are real big sources because the mosquitoes go and bite the birds. Birds infect the mosquito comes and bites us, and then they infect us. Okay? A more common one for infection would be West Nile virus, for example. Okay? We get that from a bird, and then they come and bite us, and then they spread it to us. One of those possible common complications of West Nile virus would be encephalitis. Generally, for most of us, West Nile virus is not a big deal. Usually we clear it, goes away, but there is a small possibility that it can cause encephalitis. And for these guys, we really don't have anything. We have no treatment for this thing, okay? Other than just supportive care. So prevention is the cornerstone, just like the rest of ID. Prevention is key, right? So here's a whole bunch of arboviruses that can cause encephalitis. Okay. All of these are mosquito. All of these are mosquito except for this one. Plasmon is actually a tick virus. Causes fever, headaches, vomiting, weakness. Pretty quick, usually kicks in within hours, but they're all arthropods causing the possible problem. Okay. Here's a couple other signs and symptoms of this thing. Okay. Some of these severe infections can be rapid onset of severe headaches, high fevers, muscle aches, stiffness of the neck. Generally, in about 50% of the cases, you'll have that stiffness of the neck, vomiting, seizures, weakness, paralysis. So meningitis and encephalitis really have a lot of overlapping neurologic signs and symptoms. If you go further on back into the brain stem, you'll have some of those movement disorders, or you'll have muscle coordination issues, disorientation. And this stuff can generally lead to comas and death if you don't really take care of this. So St. Louis encephalitis causes this brain problem here. If you are not sure what this brain is supposed to look like, just imagine a third of this brain less is the actual size of what it's supposed to be. This is an enlarged brain. Brain tissue is supposed to be pink to white. This brain is red, okay, probably from hemorrhage. So, enlarged bleeding brain, not good. Okay. So for arboviruses, you can look for leukocytosis, you can look for ECG changes. Obviously, we're not going to read those EEGs. Hopefully, a neurologist can read those things for you. But there's treatment, supportive, preventive, if at all possible, right? Because prevention is key. There's a whole bunch of things that you can do to prevent this thing, right? But it's up to the individual people to do those kind of things, right? Put up screens in their homes, get rid of all the standing water around their homes, use insect repellent if at all possible. So try to protect themselves. So real quick note on West Nile. It is an arbovirus. It is transmitted by birds, right? Because we said birds are common ways that these guys get this stuff. Okay. But most people with standard symptoms of West Nile virus usually have fever, weakness, nausea, vomiting. But they recover pretty quick within a couple of weeks. After they've recovered from a couple of weeks, usually the recovery from that may take a couple of more weeks, okay, from actual West Nile virus. And there, your age is one of the risk factors for this, especially for severity. Okay. Remember, most of the U.S. has this, where the mosquito goes, and in some of the southern climates, it's all year round. West Nile virus usually less than 1%. Usually less than 1% for West Nile virus causing encephalitis. Okay. But obviously that percentage is higher in the older population because they're more susceptible. Here's a whole bunch of stats. Here it's telling you in the U.S. you had 917 cases, 51 deaths in 2019 of West Nile. Okay. In 2020 you had 38 cases. We do try to do a pretty good job here controlling a lot of our insects, but again, stat slide, not going to be on the test, but just for your awareness, okay, that this stuff is still happening here in the U.S. Okay, here's some more. 29 bald eagles died in Utah. Okay. 20,000 reds died over the Great Salt Lake. And why do we point out the birds? Because the birds are the main reservoir for the mosquitoes to get this from, to possibly come and infect us. Right? So here's some signs of West Nile virus. Vast majority of mild illness are asymptomatic at all, period. Okay, we usually no issues, no problems with this. But symptoms like encephalitis may occur. Right? About 1% of folks. The other big piece to know is this flaccid paralysis. Okay? What else causes flaccid paralysis? What is it?
Botulism.
Botulism. Okay. Botulism. Polio. Okay. So, other things to think about when you see these kind of signs and symptoms as other types of differential diagnoses. Okay. Do some leukopenia. You can do serology, IgG, IgM. That'll tell you. If you have PCR, do PCR. PCR will tell you no issue, no problem. We don't have anything for any of these arbor, bugs, mosquitoes, ticks. We don't have any meds for that. So basically all that is just supportive care. We're going to stop here for today. All right. Anybody has any questions? I'll be up here for a little bit. If you have other questions you don't want to ask me here, you can text me or send me a message on that.